So what we just talked about was release, and that is release of neurotransmitter that is packaged into synaptic vesicles from the synaptic terminal. Well, the synaptic terminal is, the point of that is to get a message across to a second cell. That's the postsynaptic cell. This meeting is the synapse, and these two neurons, the cell with the synaptic terminal, which is the presynaptic cell, and the postsynaptic cell, they are separated by a short distance called the synaptic cleft. And the molecules of neurotransmitter are going to make their way over to here, where they're going to be received. We'll talk about that in the final segment. But what we're going to talk about right now is the fact that as you send this message out, as the synaptic terminal sends this message out, it has to have an endpoint. A message that doesn't have an endpoint is like a lecture that never ends, that's interminable. Not so good. So in order to make a punchy point, we have to have a beginning. We've got a great beginning because we know that release is triggered by an action potential, by calcium influx and an action potential. But now we need an endpoint. And we use 3 different mechanisms to terminate the message of a neurotransmitter. One just happens naturally, which is diffusion. These molecules are going to diffuse out. And this postsynaptic cell has ears, but those ears are only concentrated right here. So if the molecule is over here, the cell isn't hearing about it. It doesn't matter. So diffusion is a very effective way to terminate, to contribute to the termination of a message. The second way is through something called reuptake. And reuptake is typically in the presynaptic terminal, there are channels or transporters. They're actually not channels, they're called transporters. And these transporters take this neurotransmitter back up. And you'll be happy to know that neurons totally believe in recycling. They're not going to let that neurotransmitter go to waste. They'll repackage it. They'll put it right back into a new vesicle, which is actually recycled as well. And so then this cycles back. So the neurotransmitter is taken up by these reuptake inhibitors. These are reuptake transporters. So reuptake is a really, really important way to terminate messages. And this is really important for drugs like serotonin and dopamine. And there are drugs that act on the serotonin and dopamine reuptake transporters that can be used both therapeutically, for instance, to treat depression, and also that unfortunately engage circuits that lead to abuse of drugs. And so, for instance, cocaine acts on a dopamine transporter. The third way that we terminate a message is through degradation. And in the case of degradation, what we have is enzymes that sit out here in the synaptic cleft that are just chewing up this neurotransmitter. It's like Pac-Man. So they're just going to eat up this neurotransmitter, and the molecule, the neurotransmitter, where this is really, really important is acetylcholine. So in acetylcholine, there is a enzyme that sits in between the presynaptic and the postsynaptic cell that eats up that acetylcholine. It eats it up a lot. So very little of it actually makes it all the way across the synaptic cleft. If you block that enzyme, and that enzyme is called acetylcholine esterase, which is abbreviated like that. If you block that, you'll have a lot of acetylcholine. Remember that acetylcholine is the neurotransmitter that is used by motor neurons. And so, in fact, this blocking acetylcholine esterase can be used for therapeutics in the case of people that are not releasing enough acetylcholine or don't have enough receptors for the acetylcholine. We can boost the amount of acetylcholine in the cleft by inhibiting the acetylcholine esterase. And that's useful for people with things like diseases such as myasthenia gravis. We can also use, or people also use acetylcholine esterase inhibitors for nefarious purposes. And a lot of pesticides, drugs such as sarin, are based on blocking this. And the effect of that is that the acetylcholine, there's so much acetylcholine that floods this postsynaptic cell, which in the case of a motor neuron is a muscle. So the motor neuron is talking to a muscle, and now the motor neuron's not ever shutting up. That means that the muscle is contracted, and it stays contracted. Well, it's okay to contract, but it's not okay to stay contracted. So imagine if your diaphragm stayed contracted, no more breathing. And so that's the problem with these acetylcholine esterase inhibitors. Okay, and in the final segment, we're going to look at receptors. How do we hear the message? How does the postsynaptic cell hear the message? Okay, so we've almost come full circle. Now we've released a message from the presynaptic terminal, and the issue here, the next hurdle, is to make sure that the postsynaptic cell receives that message. And it receives it through a type of protein. These are actually multi-protein complexes called receptors. And receptors are going to populate this postsynaptic membrane so that as the neurotransmitter makes its way across the synaptic cleft, some portion of it, that which is not either diffused away, taken back up through reuptake, or degraded through enzymatic degradation, so that the survivors will actually make it over to these receptors. Now let's just take a look at what the receptors look like. Here's the cell membrane, and these are transmembrane protein complexes, and they form an actual pore, and through this pore, the ions can travel. So the potassium ions can go out, the sodium ions can come in, chloride ions can come in, things like that. So normally, these receptors are closed. The ions can't come in. But when a neurotransmitter binds to the receptor, or a couple of neurotransmitter molecules bind to the receptor is now going to open, and the pore becomes available for as a highway for the ions to travel along. And which way they travel depends on the type of receptor. And so as it turns out, we have 2 basic classes of receptors. There are receptors that have an excitatory effect. And so once again, if we return to our cell, which is sitting at negative 65 millivolts, any receptor that takes the membrane potential closer to zero and closer to this magical place that is the threshold for an action potential, if you go closer to that, that's an excitatory receptor. On the other hand, if there is a receptor that actually takes the membrane potential away from zero, makes it even more negative, then this is taking us away from the threshold for the action potential, and so that is an inhibitory receptor. So they come in two flavors, and the most ubiquitous excitatory receptor is a glutamate receptor, and the most ubiquitous inhibitory receptor is a GABA receptor. The neurotransmitter involved is the same thing. So the neurotransmitter involved that binds to the inhibitory GABA receptor is a GABA molecule, and the neurotransmitter that binds to the excitatory glutamate receptor is glutamate. Okay, so that's how these receptors receive the message, and they integrate all this incoming information to either make it more likely for them to fire an action potential or less likely to fire an action potential. If they're more likely, if this cell has an action potential and it results in this cell also firing an action potential, then we've got a game of telephone tag. And that's how the nervous system, that's how communication between neurons happens throughout the nervous system. Now let's think about what impact these receptors have on disease and therapeutics. So one impact is there are diseases where we lose these receptors. And one such disease is called myasthenia gravis. We mentioned this in the last segment. So in myasthenia gravis, let's walk over here to this lovely image. This is an image from a human. Here is a motor neuron synaptic terminal. And you can see these little synaptic vesicles. Okay? And so all of those synaptic vesicles contain acetylcholine, which we will abbreviate as ACH. And over here is the muscle. The muscle is it has this convoluted appearance where it has these folds. And that doesn't particularly matter, but what you see in black, all this black, these are acetylcholine receptors. And the acetylcholine has to make it across this cleft to get to the acetylcholine receptors. In myasthenia gravis, there are antibodies that the body makes, unfortunately, by mistake, against these acetylcholine receptors. And so the antibodies destroy the acetylcholine receptors. The muscle doesn't either has fewer or they're just not concentrated, and therefore this signal is sent from the motor neuron terminal, but it's not received by the muscle. And so again, as we talked about in the last segment, what do we do about that? Well, we rely on the fact that there are a few acetylcholine receptors that have escaped being killed by the antibodies, and so we just try and boost this signal. We know that the motor neuron terminal can release acetylcholine, and now we're going to stop degradation. We're going to give an acetylcholine esterase inhibitor to try and keep the acetylcholine around longer so that it can find its way to the few remaining acetylcholine receptors. And that's a pretty effective therapeutic. The other therapeutic, obviously, that people with myasthenia gravis get is let's dampen down that immune system so that you're not making all those antibodies, so that the acetylcholine receptors won't be degraded. And so there's immunosuppressants that are given to these patients as well. Okay, so far we've talked about receptors, all of one type. The type where when a neurotransmitter binds to the receptor molecule actually, or complex actually opens up and there's a pore through which ions can pass. And these receptors are called ionotropic receptors. And they are all ion channels. They're channels through which ions can pass. So ionotropic receptor and ion channel are synonyms. There are some ion channels that are not ionotropic receptors. They're instead gated by voltage rather than by a neurotransmitter. But we're talking about receptors now, and what's important is that there's a huge class of receptors that don't form a pore, and these are called metabotropic receptors. So metabotropic receptors, like ionotropic receptors, will bind neurotransmitter, but they do not directly lead to an electrical change because this molecule, this complex, cannot form a pore. Instead, this complex is attached to a G protein. So this is a G protein, and these metabotropic receptors are also called G protein coupled receptors. And so you'll see this abbreviation, GPCR, a lot. They are G protein coupled receptors. Now, so what's the deal with these metabotropic receptors? Well, why are they important? Well, first let's talk about how they're different. First of all, because these G proteins are now, once this is bound to neurotransmitter, these G proteins are now activated, and they're going to go off, and they're going to do things like stimulate enzymatic reactions, or they're going to bind to other molecules that are in turn going to stimulate enzymatic reactions. So these G proteins are going to go and do things, but that means it takes time. This ionotropic receptor binds, opens, done. Very quick, less than a millisecond. This takes milliseconds. Okay, so it has to go off and do stuff. And so first, it takes more time. The second thing is that what's the effect of this? Well, the effect could be to open a channel, an ion channel somewhere. It could be to close an ion channel. It could have no effect on ion channels. It could just go off and actually elicit a change in the genetic transcription. So it could have an electrically silent effect on the cell. So there is a huge variation in effect. Another thing that is different about these metabotropic receptors is that they're incredibly numerous and varied. There are more than 1,000 types, and there are less than 10 types of ionotropic receptors. So one final way to think about this is not only does it take time to activate, to see the effect of a metabotropic receptor activation, but the metabotropic receptor amplifies. It goes through many rounds of activating these G proteins. And so it can have a lasting effect that is pretty difficult to turn off. And so one way to think about this is to contrast something such as the knee-jerk reflex, the stretch reflex that a physician evokes when you're sitting in the doctor's office. That's all based on ionotropic receptors, versus something like the release of adrenaline when you get really scared. Okay, so you feel like you're about to crash, and you have this incredible rush of adrenaline, and that leads to an increase in blood pressure and heart rate, and you're breathing faster. Well, can you turn that off? Can you turn that off on a dime? Not so much. That's really hard to turn off. And one of the things is that it's not only that it takes time for that to happen, it doesn't feel like it takes that much time, but it does take longer than it takes for the ionotropic receptors, but it takes then seconds to minutes for that to turn off. You just simply can't turn off the metabotropic receptors very quickly. Okay, so are these important in your lives? Well, I looked up what are the most commonly prescribed drugs in the United States. And the most commonly prescribed drug is a drug called Vicodin, which is a mix of hydrocodone and acetaminophen. Acetaminophen is a different deal, but hydrocodone, which is the big deal in Vicodin, is acting on a G protein coupled receptor, on the mu opioid receptor. So similarly, all of the autonomic target organs are using metabotropic receptors. Consequently, all of those drugs that we use, not all of them, but many of the drugs that we use to treat glaucoma, motion sickness, arrhythmias, hypertension, asthma, irritable bowel syndrome, and so on, many of those drugs are acting on G protein coupled receptors. So this is a very common target for drug development, these G protein coupled receptors. Okay, in the next segment, we'll wrap up neurotransmission. So in this unit, what we've seen is how one neuron can formulate a message in terms of action potentials and send that message on to another cell which can receive the message. And that is a fascinating topic. And yet, if we knew all the details, everything that we ever could wish to know about how, for instance, neurotransmitter release occurs, if we knew every single detail, it would not tell us what would happen if the system failed. Let's put it another way. Think about a demyelinating disease. If we knew everything about how myelin formed and everything about how it fell apart, it wouldn't tell us what are going to be the symptoms in a person with, say, multiple sclerosis, because the symptoms depend not on the particular pathophysiology of how the myelin falls apart. It depends on which neurons are affected. And so now we have to take our knowledge about neuronal communication and put it within the context of the incredible complexity of neuroanatomy. It depends on which neurons are affected. And so we're going to look at neuroanatomy. We're going to look at what does the brain do, what does the brainstem do, what does the spinal cord, how does the peripheral, how does information come in from the periphery and go back out to the muscles. And that's what we'll do in the next unit. Hi there. Okay, so in this module, we're going to look at how emotions are produced by and depend upon the feeling of the body. And just to get us started, let's look at a couple images. Now here is one of my 3 darling cats. This cat is, she's a kitten at this point. And you see that her hair is raised. She's piloerected. She is very alert. And she has a feeling that she's about to go catch something and try and kill it, try and hunt. And this is her affect. Now, let's look at another picture. This is my nephew, bungee jumping. And he's just leaped off a cliff to go into the unknown. Okay, I'm not doing this. He did this. I'm very impressed. But the point being that his emotion is all wrapped up in exactly what he's doing. He's very aroused and excited. This is not a situation where he's contemplative. He's not depressed. He's not. There are only certain moods that are available to him because of the state of his body. And let's look at a couple more pictures. Here's another one of my cats, Gree. And Gree is, this is a picture that we call the blissed out Gree. She's sleepy. She's not about to bungee jump. She's not about to hunt. And here's Zoe, very sleepy. And Zoe and Gree are kind of in the same mood there. So the point being that that emotions depend on body states. Part of the body states are voluntarily produced, and part of the body states are automatically produced. We're going to focus on the automatic part. There's been a long controversy since William James as to whether emotion comes from the body or the body state comes from the emotion. So to put it in other words, you run away from the bear because you run away from the bear to get away from the bear, and that makes you scared, or you get scared and therefore you run away from the bear. Which of those two is true? Probably neither. Probably they both work in concert. Every once in a while they don't work in concert, and that's what we think happens, for instance, in a panic attack. In a panic attack, it's all first body. First you get this whole blown up arousal, freak out, and then the emotion stems from that body. But normally, under most circumstances, body and brain are producing one body-brain emotion, one state altogether. So in this module, we're not going to talk all about emotions. We're really going to focus on the automatic body part of emotions. And we're going to primarily focus on, not exclusively, but primarily focus on the sympathetics and the parasympathetics. So the sympathetic and the parasympathetic nervous systems that give rise to these automatic body states. Great. So even though I told you we're going to concentrate on the sympathetics and the parasympathetics, we're going to start by looking at the third part of the autonomic nervous system, which is the enteric nervous system. And the enteric nervous system is one that's shared throughout the vertebrates, and it lines the digestive tract from the esophagus through the stomach, through the small intestine, and then through the large intestine and down to the anus. And throughout that length, there are intrinsic neurons that sit in the lining, in the gastrointestinal tract. And these neurons form the enteric nervous system. And there are about 100 million. And these, they form two different plexuses. One of the plexuses is responsible for pushing the contents of the digestive tract through. So peristalsis, this is pumping the contents of what we eat through the pathway from mouth to anus. The other plexus is responsible for secreting stuff, so making our feces either more or less watery. And food is absorbed through this gastrointestinal tract. So the way that this enteric nervous system works is that it's very automatic. This is the most automatic of the autonomic nervous system. If you just took this, it will push the food through. And so we're not doing anything conscious to push the food through from esophagus to anus. That's all taken care of by the enteric nervous system. As you may imagine, if you don't have an enteric nervous system, then food doesn't get pushed through. And that actually happens in a disease called Hirschsprung's disease. And Hirschsprung's disease is identified at birth. So these kids come in and they have Hirschsprung's because a section of the GI tract, typically down here, is aganglionic. It has no neurons, and therefore it's just contracted. And everything can push down, but it can't push through that contraction. This has to be fixed surgically. So what they do is they take an innervated piece of the digestive tract and they just replace the uninnervated, the aganglionic portion with that innervated portion, and then all is well. Another name for Hirschsprung's is megacolon. So megacolon, they've gotten this in large colon because nothing's going through. The other aspect of this, besides the automaticity that's very interesting, is how this influences our mood and emotion. And while the enteric nervous system is completely able to do all this peristalsis stuff on its own, it does interact with the central nervous system. And this is how it interacts. There's information going to the central nervous system, a lot, and there's some information coming from the central nervous system to the enteric nervous system. This is all coming to it through the parasympathetics and the sympathetics. You notice that I wrote two differently sized arrows because the information coming out of the enteric nervous system is about 10 times more than the information that's going to the enteric nervous system. That information that comes from the digestive tract is telling us about whether we feel full, whether we just ate Thanksgiving meal and our abdomen is distended, whether we feel gassy, whether we feel hungry, whether we feel good. It is telling us about the state of our GI tract. The information going to the enteric nervous system is a way by which our mood can now influence our GI functioning. And this is the way that if you get very nervous or excited, you may notice a difference in your bowel movements. If you get if you're very calm, that's a different state. And so there's an interaction between the way our digestive tract, our GI tract feels and the way we feel emotionally. Not surprisingly, many psychiatric diseases are associated with certain GI issues as well. And so this is, I think it's a really great example of how the state of the body, just how we feel somatically influences how we feel in our brain, how we feel emotionally. Okay, let's get to the heart of the matter, the sympathetic and the parasympathetic systems. These are two different systems, but they both work through these two chain neurons. They're both automatic, and they're both motor systems that are targeting three different types of tissues: smooth muscle, cardiac muscle, and glands. And in general, the sympathetic system is called the fight or flight system. Fight or flight or bungee jump, as the case may be. The parasympathetic system is the rest and digest, sleep, recuperate from injury, all that kind of thing. And so they're working in opposition. They're working to produce different functional ends. The thoracic cord, the sympathetic system comes entirely from neurons in the thoracic cord. The parasympathetic system comes from two places: the cranium, so these are coming out through cranial nerves, and then also from the sacral cord. And so because of that, this is often called the craniosacral system. The parasympathetics are the craniosacral system. But let's take a few examples of how these two systems work in opposition. And the first example is the heart. So the parasympathetics innervate the heart, and they drive heart rate down. The sympathetics innervate the heart, and they drive heart rate up. Another example is in the eye. The parasympathetics come out of the cranium to innervate the eye, and they make the pupil small, and the sympathetics come out and they make the pupil big. So they're working in opposition. There are also certain places where they don't as much work in opposition. They do different things. So the sacral cord is innervating three tissues. It's innervating the bladder, the colon, and the sexual organs. And the thoracic cord innervates those too, but they do different things. For instance, sacral cord, the parasympathetics are critical to sexual arousal, whereas the sympathetics are critical to sexual climax. You can also see that there's a topography. So up here, the stuff up here is going to go towards the head. The stuff down here is going to go towards the tail. Now, the final point that I want to make here is that the sympathetics they have a few special places that only they innervate. And we're going to name, I think, 3 of them. So one is sweat glands. Sweat glands are turned on by the sympathetic system, and there's no turning them off, for instance, by the parasympathetic. Parasympathetics have nothing to do with the sweat glands. So they're turned on by the sympathetics. Piloerection is actually a fourth one, piloerection. We saw Tula very piloerected as she was about to go try and hunt something. That's coming from the sympathetics. Another one is the cutaneous, meaning skin, cutaneous blood vessels. Now that sounds really obscure, but the point of the cutaneous blood vessels is whether they are constricted or dilated. And the parasympathetics have nothing to do with that. The sympathetics completely control that. So for instance, as you're exercising, you build up heat, start sweating, and you also dilate your vessels to release heat into the environment. So this is only innervated by the sympathetic system. Another consequence of whether there is more or less blood going to the skin is whether your blood pressure is going to go up or down. So if you send a lot of blood into your skin, blood pressure will go down because it's filling a larger volume. And if you constrict your skin blood vessels, your blood pressure will go down. And that's a major way in which we control blood pressure, is through the cutaneous blood vessels, the state of the cutaneous blood vessels. The final tissue that is only innervated by the sympathetics that we're going to talk about is the adrenal medulla. And the adrenal medulla is the organ, the gland, that pumps out cortisol. And cortisol is a stress hormone. It's absolutely critical. This is lacking in people with Addison's disease, people such as John Fitzgerald Kennedy, our president from 1960 to 1963. And I was recently watching some historic footage of him, and it's remarkable how, knowing that he's got a bad case of Addison's. I mean, there's not a particularly good case of Addison's to be had, but he was an ill man, and you can see it in the way he walks and the gingerly way in which he moves. And this is a very serious disease, and it comes from a lack of the output of the adrenal medulla. Okay, so the parasympathetic and the sympathetic systems are commonly known as fight or flight and rest or digest. And that's true. That's true if we were always at full sympathetic tone or at full parasympathetic tone. That's not the case. Usually we're somewhere in the middle. We're bopping along over here. Something happens, a mouse runs by, and Tula goes into there. Tula's been out for 4 hours. She comes inside. She eats some crunchies and good, tasty food. And now she's down here and she takes a nap. So moment to moment, this is changing. There's another scale at which our parasympathetic and our sympathetic tone changes, and that is across our life cycle. So now this is on a short time scale where we can go sympathetic or parasympathetic according to the needs of the moment. But as we go from being born to old age, we are moving in a steady direction towards more sympathetically dominated. All right, so young kids are very parasympathetically dominated. Their job is to grow. Their job is to absorb nutrients. They run around, but their job really is to grow, and they do a lot of growing. Over here, we're sympathetically dominated. Now, there are other conditions which will bias an individual towards parasympathetic or sympathetic. So for instance, very good athletes, and I'm talking very good aerobic athletes, are very parasympathetic. So you can have a 20-year-old that's down here. These 20, 30-year-olds that are cyclists, for instance, in the old days, in the Tour de France, these are not steroid cyclists. These are not. So they had resting heart rates of about 30 beats per minute. So that's very, very low. A normal individual at rest might have a heart rate of around 60 to 70. So, so that's very low. So parasympathetic domination is in athletes. Now, once you get into older age, if you think about it, the sympathetic domination is going to drive up heart rate, and it's going to drive up blood pressure. And what does that sound like? That sounds like hypertension. And so this sympathetic activity, the sympathetic tone, is probably the reason why individuals go through their entire life, they're just peachy keen, they reach 50, 60, 70, and all of a sudden they have hypertension. But nothing's changed except now they're sufficiently sympathetically dominated that now they've encountered this hypertension. And in the next segment, we're going to talk about how we can use drugs that work on the autonomic nervous system to combat things like hypertension. Okay, so we're going to talk about the pharmacology of the autonomic nervous system. Now, this pharmacology is rich. It is so rich that it is what people throughout all medical disciplines use to treat a number of conditions. And most notably, we'll focus on cardiac conditions and glaucoma. So, but let's start with the basics. So in both situations, in both the sympathetic system, which is right here, and the parasympathetic system, which is right here,